It is about 10 months since the launch of the Universal Health Coverage pilot phase in Kisumu County, Isiolo, Nyeri and Machakos counties. And during the launch, the government said that this pilot phase of UHC will focus on the primary health care. This means that citizens in these 4 counties would be able to enjoy quality and timely health services at an affordable price or without any financial constraints. And we are looking at 2 months before this program could be launched to the other 43 counties. And today we want to reflect on some of the lessons learned in the 10 months of the pilot phase in the 4 counties, and of course what are some of the successes and how the government is now planning to roll out the UHC program to the rest of the country. I am privileged to have the Health Cabinet Secretary Sicily Kariuki, who will be helping us in this discussion on UHC milestone. My name is Museo and welcome to this program. Help me now welcome the CS. Thank you so much for your time.
Thank you, Purity.
Yeah, and I hope you had a lovely day.
I did, thank you very much. I hope so too for you.
Yes, I did. So let's reflect on the UHC. We launched this UHC pilot phase in Kisumu County in December 2018, and there were so many expectations, especially on the lessons that we should pick from the pilot phase as we look forward to rolling it out in the rest of the 43 counties. Maybe let's reflect, what would you tell of the UHC 10 months later?
Thank you very much, Purity. And the UHC story in the pilot phase is best understood by you speaking to the beneficiaries of this intervention in the 4 counties that you mentioned. I have taken time to visit these counties once in a while, and the joy, the positive energy, the excitement, the hope that the residents of these counties and the neighboring counties have can only be told at their own space. From where I sit as government and the CS for Health now, I am happy with the feedback that I receive from ordinary Kenyans. I am happy to also be exposed to the gaps that may have exhibited in the process of doing the pilot, but I'm also happy to get my team and I and the governors who are responsible to respond in dealing with the gaps that have emanated. Overall, if I was to quote one of the governors in one of the pilots, only this week, he says to me that UHC at pilot stage has brought new hope, anticipation of how the future will look like. And the questions are, so shall we continue or what happens next year? That just comes to summarize the kind of success, if we will, that we've had at the individual and family level during this pilot phase.
Yeah.
That does not mean there hasn't been challenges. We have experienced challenges. We expected. The reason you move a program at a pilot stage is so that you pick the positives and the likely negatives, and also craft a way of mitigating when you come across the negatives. This is exactly the journey that you have walked from 13th of December last year, when we launched the UHC at pilots.
Yes, and before the launch, of course, we were saying this is what we are keen on doing, but as officials, health officials and officers from the government and ministry got to the grassroots and interact with the people, of course they learn more lessons, especially on interacting with people, implementation of this UHC, the focus being the primary provision of primary health care to citizens in this. Maybe the feedback that you have been able to get, where is the gap as we look forward to rolling it out to other 43 counties? Where would you say is the gap? Because also you had mentioned the stakeholders that you needed to partner with. We had KEMSA, we had NHIF. Maybe you can tell us where the gap and whether these stakeholders that you mandated to ensure the pilot phase is a success, successfully did their work or their job well.
Purity, allow me to put it the other way around.
Yeah.
Between the 4 counties, we have recorded an increase of the population or traffic in the health facilities. Remember, these are public facilities. Anywhere from 25% to close to 50% new traffic or additional traffic. What that meant for us is that this 25 to 50% population that is coming out suddenly to public facilities is two things. One, the confidence has been built that because they know they are going to find medicines, they are going to find human resource, that they are going to be attended to, they then are willing and happy to come to the public facilities, or to avoid going to the usual duka kiosks where they would go to get their medication and prescribe, self-prescription. Number one, what that has also meant for us is that indeed the out-of-pocket conversation, currently we've documented 27% of healthcare are through out-of-pocket. You have to go, you have to pay, and then you have to make a decision whether that day the choice is a meal, is a new dress, is a trip, or it is medicine and healthcare. So that's 27% out-of-pocket expenditure for this traffic that has gone to the facility, has been treated, means is money that has been retained by the individual or the family to cater for alternative requirements. And that is very, very positive. Number two, we have also confirmed that you cannot move one element of the health building blocks. You cannot move one intervention in isolation or the other. That the system has to move as a system. And that is why it's called a health system. You cannot avail medicines without a proportionate increase in human resource to be able to then attend. Likewise, you cannot have a functioning referral mechanism. Like we have a strategy on referral, so that you start with the lowest level of a health care facility, move upwards or escalate that depending on the disease condition or the complication that you have. We have also confirmed that that referral mechanism cannot, and in itself, work unless and until all the levels of the healthcare delivery system are together. So again, confirmation that it has to be a whole system-wide approach moving forward. We have also gotten to then confirm and tweak where we had challenges. For example, what we call the essential health benefits package has been defined by different providers in different ways. It's come out loud and very clear that we have to have a common reference point of what is referred as essential benefits package, which is essential whether you're in Machakos, essential whether you're in Nairobi, and it meets the basic minimum for us to be able to deliver affordable health care. I'm very happy to note that some of the lessons picked have then reawakened the teams that are planning, or the architects. What has also come very, very loud, it could be a positive but also tilted the other way around, a negative, is that we must strengthen our data capture capability for decision making. Again, interpretation of what constitutes a health indicator has to be defined within parameters that are commonly understood. But if you flip the other way around, you look at gaps that we have experienced up to and including KEMSA's capability to be the premium provider of pharmaceuticals and pharmaceutical commodities. And the question then that we have asked, they have done a good job. They have managed to do upwards of 70% of the requirements that the counties place to them. But there has been a question of the lead time, how long it's taking for them to actually be able to fulfill the requirements. Remember, this is a system issue. It's continuous, 365 days, 24/7. They must be able to be on the wheels to deliver and satisfy the requirements of the counties. It has therefore said to us, we have to be a bit more innovative in the mechanics of delivering this service. It has said to us that KEMSA, while they have a very wide range of pharmaceuticals, for example, it's come out clear that there is a minimum range that they must hold at any one point. What has that meant for us? Because they may not have the capacity for warehousing all the requirements, as it were, they have to go backwards and have a negotiation with the manufacturers of these commodities and be able to employ what we call a just-in-time mechanics of delivering the pharmaceuticals for them to be able to, one, deliver what is being required and be able to do it in good time. But what has also come out clear is that KEMSA has to employ like-minded organizations within the framework for them to have the right capability. And here, MEDS, which is within the faith-based framework of availing commodities, that is drugs and non-pharmaceuticals, comes a very necessary complementer to what KEMS is doing within a framework that has been negotiated.
Right.
Now, moving on to the insurance component, you will recall that NHIF had an important role when we started. And NHIF's role was to continue to insure those that are qualified voluntarily, but also the former ones, which is a mandatory component of the main business of NHIF. But they came in to support us with identification and kitting through a card. We called it the UHC card. The entire population in these 4 counties. The population then was 3.2 targeted. They did a good job because they were able to do a mapping and identify every one of these residents who are not on regular insurance. But as we went into the second month, it was apparent that the traffic from the neighboring counties that knew there was free care at that point in time would necessarily go to access care. Now the choice became, do you get held up because of the UHC card, or do you treat the lady who has walked over from Muranga and moved into Nyeri, do you tell her to go back because you are not treated? Do you tell the gentleman from Meru who has moved to Isiolo that we can't treat you because, or what is the balance? And in Kisumu, really, people coming from the neighboring counties, do you tell them go back because you don't have a UHC card? And the policy decision that had to be made was, if they come in and with identification really and they are Kenyans, allow them. They must really be treated. That is the most logical thing to be done. So while the card had good intentions, while NHIF did the work that they did, we had to act a bit flexible. Otherwise, we are going to get ourselves into a little bit of a backlash from the neighboring counties. Yeah. So overall, everybody actually did what they needed to do. They did it very well because the monitoring was very intense. They all were exposed to the gaps and the additional work that await them, which has been part of the planning processes now before we go full throttle. The counties, fantastic, because really the human resource, the facilities, the warehouses, the monitoring day to day was in the hands of the counties. Again, recall we came in as a ministry to lead this process, but to also monitor the performance for us to be able to plan better. But the actual person who implements UHC is a county government. Recalling again, this is a devolved function. But I would say we've done this with a lot of consultation and collaboration. Whenever there was a problem that we experienced, we came back and consulted and had to resolve. Yeah. I'll bring one more issue that has come out because it's important for all of us to know. As we moved around the counties, there was a challenge because of lack of standardization, particularly of medical equipment. You have hundreds of manufacturers with hundreds of different equipments in County X. What that means for us is that the reagents to be utilized in some of these equipments are not standardized. And therefore, the economies of scale, which is the very reason that we wanted then to bulk procure, would be lost. And that continued to be a challenge. That has taught us that we really have to standardize the equipment across for us to be able then to get reagents from a position that is in a bulky position, if you will, for us to then ensure the pricing is that much competitive. Right. All very useful lessons we have learned.
Yeah, and it's something that I could pick from what you've mentioned about NHIF and KEMSA is that moving forward they need to really pull up their stocks, especially KEMSA, to 100%, because you mentioned they have been able to supply the pharmaceutical for at only 70%. So the 30% remaining, maybe it's something that they should be looking at. But then there is also the issue of personnel. Maybe during this UHC, because you're saying you have been able to work with consultatively with all necessary stakeholders, maybe we can also, the issue of maybe enough personnel as well, as it been a challenge or especially for those 4 counties, or they were taken care of, and then as we go now to the other 43 counties, maybe do we have a need as a country to have more health professionals to ensure UHC is a success?
Well, a very useful observation, and KEMSA, NHIF, my own ministry, the counties themselves, every one of us will have to pull up their socks, not just one.
Yeah.
And the reason we must pull up our socks is very simple to me. The reason we didn't attain UHC status for everybody accessing affordable health care that is of high quality and that is sustainable is because we did things in a certain way. For us then to say that we have turned the page and indeed Kenyans are able to access quality, affordable health care that is sustainable, we cannot do the things that we did yesterday. We can't do the things that we did the day before yesterday, meaning all of us have been summoned to look at things differently, to operate differently, to borrow more efficiency in the decisions and the interventions that we take, to be more collaborative in the manner that we act, but to also stretch the investment to yield that much more required health input and positive outcome as opposed to what it is we did before. So KEMSA, everyone is on notice. Pull up your socks, do what must be done, because we want medicine, we want drugs that are cheap, that are of good quality, that are available when we need it.
Yeah.
NHIF, pull up your socks, and we have a serious reform agenda for NHIF. Come along, keep your mandatory clientele, which you are mandated by law, because civil servants and people who are employed will continue paying into NHIF. But give quality and don't allow governance issues to be commonplace discussion every day. So you got to pull up your socks. My own ministry, issues of accrediting facilities, issues of ensuring you are monitoring on quality and what that means for all of us. Pull up your socks. Your investments, my colleagues and I in this ministry, put your investment where your mouth is. Where our mouth is today in matters UHC is a primary health care level or facilities. That is at the community, it is a level 2, that is a dispensary, it is at the health center, it is at levels 4, and be able to establish a network that helps this system at the lower level to be able to speak to each other. If drugs are available in level 3 and for some reason they are needed in level 2, work up a mechanism that medicine can be able to move where it is required. So as opposed to the patient coming where the medicine is, make sure that you avail. So all of us must pull up our socks.
Yeah.
I speak to the issue of human resource because it's very important. Globally, the human resource capabilities or capacities in terms of numbers and expertise, especially the specialized cadres, vis-a-vis population, there's a mismatch. There's less HR than is required in terms of the ratio to population. That is true of the globe, it is true of Kenya. So the anticipation when we went to the pilot was that these 4 pilot counties were going to initially increase their human resource by 12.5% within the year. None of the 4 counties have actually managed to do that. We have on average attained 5% as opposed to 12.5% for good reasons, various reasons. One, employing more persons required bureaucratic processes and approvals from the boards, the public service boards in the respective counties. Number 2, even where the counties applied, called for human resource to apply and express interest, it didn't happen within the time, because remember, again, that's a very short time. Number 3, I would say, and this is something that we've agreed we have to be better at, implementation of the community health strategy equitably also was not attained. We identified the community volunteers in the 4. We took them through the training, all at the same time, but they required to be on a stipend, some minimum resource that helps them to move from one place to another. It was not uniformly applied, and therefore we didn't I wouldn't say we achieved that as a target that we had set. Yet, community health volunteers are very central to our achievement of UHC, using primary health care as the anchor. So it continues to be a very important investment that we all must invest in. And we hopefully, with better planning, with the lessons that we have taken out again, will be careful to go back to what I've just told you. That without human resource, drugs alone will not give us what we are looking for. With human resource alone, without drugs, it will not give us what it is we are looking for. So all these components have to go together.
Yeah. And now, 2 months before the end of the year, and of course before the completion of this pilot phase, from the challenges and from what you indicated, that in the 4 counties, maybe the health facilities in those 4 counties have been able to witness a lot of traffic when it comes to people moving from other counties and visiting health facilities because of the improved health services and of course affordable health services. So it's something I guess the government is not planning to stop. So in the next 2 months, what can be done? And then when now do we expect the UHC or residents, Kenyans in other 43 counties to begin enjoying these UHC services?
With a degree of confidence, I'll tell you, we are not stopping UHC with a degree of confidence. And that is because the president continues to be committed and determined that that is one of his legacy pillars. Number 2, because we've already started this investment journey with a lot of support from our partners across the board. I, on a regular basis, will be hosting on an average maybe 2-3 partners each week. And every one of them is looking to say, how can we support you on this noble journey? Number 3, the governors themselves are committed to the UHC agenda. The issues of who is going to invest where, how we are going to invest what, are conversations which currently are perhaps at a very advanced stage between my office and that of the Council of Governors, as it were. Pleased to note that this Monday, we actually put in 3 hours in a meeting that the Council of Governors chairperson and I co-chaired, and we were looking at the moving parts. What do we need to do where, and who does what when? That meeting that we had this Monday this week will culminate into a meeting of a task force that we put together, which is working through this week and the coming week. And hopefully by Friday, the coming week, we'll be able then to come back and say we're on the same platform in terms of understanding. We have prioritized what requires to be prioritized, from human resource to equipment to the monitoring framework and the timelines. Now, it will be the honors of the president to then be able to say, is it December, is it January? Once he is now confirmed that we've had our meetings, we've aligned everything with the governors, and we'll be ready to move. But I can tell you there has been a lot of planning, there's been a lot of reflections being taken. There have been a lot of bringing everybody that matters on board, including what we call the enabling ministries and departments in government. For example, ministry responsible for water and sanitation is one of my most important enabler. Why? Because we need clean water in the health facilities. The minister responsible for energy, electricity, is very important for me, because we cannot